Hello students, so this is the last part of your WBC's chapter and we're going to be focusing on chronic myeloproliferative disorders. This is not something that is asked routinely. However, from the AIMS questions, there were some questions that were asked on essential thrombocytosis as well as on polycythemia vera, and that is the reason why we decided to include it. Polycythemia vera is actually an important topic. Uh, Though not a lot of questions are asked, the only one question that was primarily asked on this was the JAK2 mutation. Okay, this is the gene that is mutation of this gene. Basically, it leads to a variety of chronic myeloproliferative disorders. In that, polycythemia vera is the most important. So, coming to your chronic myeloproliferative disorders, they can be broadly classified into the following types based on the cell of origin, that is from which origin they are, which cell they are coming. They can be classified into the myeloid series. In myeloid series, you have chronic myeloid leukemia as the main important one. In the erythroid series, you have polycythemia vera. In the megakaryocyte, you have essential thrombocytosis and fibroblast. This is also important because it is myeloproliferative, myeloid series and myo. That is the reason it is fibroblast. In fibroblast, you have something called as idiopathic myelofibrosis, wherein the entire bone marrow which is there, it gets converted actually into fibrous tissue. There is a lot of fibroblasts which get activated. The myeloid series actually get converted into another type. They undergo metaplasia, and as a result, there is a lot of fibroblasts which are produced within the bone marrow. Okay. Amongst all of these, we've already covered chronic myeloid leukemia. Now, coming to polycythemia vera, this is actually the only part which is important, and there's a difference between polycythemia vera and absolute polycythemia. See, what is polycythemia? Polycythemia is nothing but an increase in the number of RBCs more than their normal value. So that is what is polycythemia. Now, in absolute polycythemia, what exactly happens is you have a lot of RBCs which are being produced because there is an increase in the demand for RBCs. As a result, the factors which lead to differentiation of the erythroblasts to give rise to mature RBCs have increased. On the other hand, in polycythemia vera, there is a mutation which has occurred because of which you have too many RBCs which are being produced, and as a result, the body is actually trying to reduce the factors which would lead to an increase in the number of RBCs. So that is negative feedback, whereas in absolute polycythemia, you have positive feedback. Okay. So one of the most important differentiating features between polycythemia vera and absolute polycythemia is in polycythemia vera you have decreased erythropoietin, whereas in absolute polycythemia you have increased erythropoietin. Why? Because increased erythropoietin would lead to increase in the differentiation of erythroblasts to give rise to RBCs, whereas in polycythemia vera, since there are already way too many RBCs, the body is decreasing the production of erythropoietin, and as a result of that, the stimulus for uh, differentiation of erythroblasts to RBCs is gradually decreasing. That is why you have decreased erythropoietin in polycythemia. Okay. Now, in polycythemia vera, one more important thing that you need to remember is that there is a decrease in the ESR. Another condition where you have a decrease in the ESR is sickle cell anemia. Okay. Now, coming to these four parts that we spoke about, in this you have something called as the LAP scores, that is the leukocyte adhesion particle scores. These LAP scores are decreased in chronic myeloid leukemia where and hemoglobinuria, but you need to remember that in CML there is decreased LAP score. Okay, that is one more differentiating feature how you can differentiate the myeloproliferative disorders. Now, this polycythemia vera that we are talking about for so long, it is also called as Osler Vasquez syndrome. Okay, this is an important question because the Osler-Vasquez syndrome was asked as an MCQ. The synonym was asked as an MCQ in one of the Neet questions. Whereas the clinical features that you're going to be seeing probably for this is going to be is that you will have sluggish blood flow, and in addition to that, you will have venous thrombosis. And a very characteristic feature of chronic myeloproliferative diseases is that there is an increase in the number of basophils. They are seen in all of these myeloid, this CML, PV, ET as well as IM. The number of basophils is very high. This is one important and pathognomic feature of chronic myeloproliferative diseases. Okay. Now, from an exam point of view, one thing that you need to remember is the major and the minor criteria to diagnose a patient who has come to you if they have polycythemia vera. There are certain criteria that you need to, that the WHO has recommended, and you have to use these criteria to diagnose a patient that this particular patient is suffering from polycythemia vera. So the criteria are broadly classified into two types. You have the major criteria and the minor criteria. In the major criteria, you need to know that the hemoglobin level should be greater than 18.5 gram per deciliter for men and greater than 16.5 gram per deciliter for women, and there should be a presence of JAK2, the JAK2 mutation. Okay, whereas the minor criteria are, you have a hypocellular bone marrow, an increase in the number of cells of the bone marrow with prominent erythroid granulocytic and megakaryocytic hyperplasia. You have decreased erythropoietin in the serum, and you have in vitro, that means you take the blood and you try to culture it. Then in vitro you will have uh, erythroid series, the colonies of the erythroid cells, they will be present characteristically in polycythemia vera. So these are the minor criteria that is there. In order to categorize, you need to know that there should be a presence of both the major as well as the minor criteria. Okay. That is how you would identify whether the patient is going to be diagnosed with polycythemia vera or not. Now, the treatment for this condition is going to be either you give the patient, because it is ultimately a proliferative disorder, you would want to inhibit the proliferation. And again over here, remember I spoke about the major and the minor. So in the major, you need to know that it should have either 2 major plus 1 minor, or it should have the first major, that is over here greater than 18.5 or greater than 16.5, along with 2 minor criteria. That is how you diagnose a patient with polycythemia vera. Sorry that I drifted apart. Now, for the treatment, you are going to be giving the patient an immunomodulatory drug. At the same time, you might have to give the patient an interferon so that there is a decrease in the proliferation. Apart from that, you would also have to give the patient, if there is so much RBCs that are being produced, you would have to probably do blood transfusion so that the patient's RBCs can be decreased, or you might, so there are this number of surgeries or the number of treatment options are varied for such patients. See, in this, what the most important one is phlebotomy, that is also called as venesection, where you actually remove blood from the patient. So this is a procedure which is performed so that the number of RBCs which are circulating in the blood can be decreased. So it is supposed to be kept at a hematocrit value of less than 45% after 3 months of at least 2 grams per day of hydroxyurea. Hydroxyurea is actually an immunomodulatory drug, and it is also a chemotherapeutic agent which helps in decreasing the proliferation of the cells. Then uncontrolled myeloproliferation, if this is, that is, if the platelet count is greater than 400, in such situations, you might have to also undergo a splenomegaly. Sorry, if the splenomegaly occurs because there is so much production or destruction of the cells, because there is so much cells that are being produced, the spleen is trying to destroy those cells. As a result, the spleen is becoming hypertrophic. So there will be massive splenomegaly. In order to prevent that, you might have to even remove the spleen, or you might have to cut a part of the spleen so that, or you have to perform a splenectomy so that the number of cells or the size of the spleen is decreased and other parts of the body or the other organs are not impinged by the spleen. In a nutshell, what you need to remember for polycythemia vera is the major and the minor criteria. And in addition to that, you need to remember is the treatment options are two most important. One is you perform a venesection or a phlebotomy, and the second one is you give the patient alpha interferon. These are the two most important things that you need to remember. Apart from that, this chapter is not very important. We'll just run and skim through your workbooks fast so that we can finish off this section. Coming to your workbooks, the common pathogenic feature of myeloproliferative disorders is the presence of mutated, constitutively activated tyrosine kinase enzyme, which led to growth factor independent proliferation and survival of marrow progenitor cells. These arise from clonal proliferation of multipotent stem cells which proliferate along three lines, that is erythroid, megakaryocytic and granulocytic, except in CML, which is a pluripotent cell give rise to the myeloid series. The disorders are CML, PV, primary myelofibrosis, thrombocytopenia, chronic eosinophilic leukemia, systemic mastocytosis, stem cell leukemia. However, these four are considered to be the most important right now. Okay. So, depending upon the cell, like I said over here, you have CML, you have polycythemia vera, essential thrombocytosis, and idiopathic myelofibrosis. All myeloproliferative diseases have increased leukocyte alkaline phosphatase scores except chronic myeloid leukemia. Polycythemia vera, a myeloproliferative disorder characterized by an increase in the number of erythroid, granulocytic, and megakaryocytic cells. Polycythemia vera progenitor cells have markedly decreased requirement for erythropoietin and other hematopoietic growth factor. We've seen the reason why. Clinical features include increase in the hematocrit rate and red cell mass contributing to sluggish blood flow and even increased chances of thrombosis. We've already seen this. These manifest in the form of dusky cyanosis, visual disturbances, headache, venous thrombosis, which causes venous thrombosis in the head, which causes Budd-Chiari syndrome, which is due to hepatic vein thrombosis, bowel infarction stroke, sorry. Then the increased basophil releases histamine, and as a result of that increased release of histamine, you end up having patients with pruritus as well as itching sensation. Then this also causes increased peptic ulcer. You have hyperuricemia, splenomegaly, which is due to extramedullary hematopoiesis. The proposed revised WHO classification for polycythemia vera is, again, you have the major and the minor criteria. We've seen all of this. The investigations include elevated hemoglobin, red cell count, increased hematocrit with a decreased level of erythropoietin, increased basophils and normal platelets, hypercellular bone marrow having increased number of erythrocytic, granulocytic and megakaryocytic cells. In the later stages, there is presence of myelofibrosis. The diagnosis is presence of both the major criteria, that is we had spoken about, two major criteria and one minor criteria, or the presence of the first major criteria and two minor criteria. Essential thrombocytosis, all of these myeloproliferative disorders are caused by activation of the JAK2 gene. So again over here you will have mutation in the JAK2 gene, more commonly MPL receptor tyrosine kinase, increased megakaryocytes in the bone marrow, high platelet count, and normal level is 1.5 to 4.5 lakh per millimeter cube. Clinical features is non-functioning platelets. As a result of that, the bleeding time is increased post-trauma. Thrombosis resulting in dizziness, ischemia of the digits, because these are end arteries. So over there, if you go and have platelets that are getting accumulated, you will have ischemia over there. Investigations include hypercellular bone marrow with increased number of giant megakaryocytes, erythroid and myeloid cells, show only mild hyperplasia. Elevated platelet count in the blood, normal hemoglobin levels and elevated LAP scores. Coming to idiopathic or primary myelofibrosis, it is characterized by the presence of myelofibrosis activated with extramedullary hemopoiesis in the spleen in old patients. It is associated with activated mutation in JAK2 gene. The presence of neoplastic megakaryocytes responsible for the release of fibrogenic factors like PDGF and TGF beta, that is transforming growth factor beta. These factors cause progress of marrow fibrosis. There is dry tap on bone marrow aspiration. Teardrop, that is dacrocytes, teardrop RBCs are seen, and leukoerythroblastosia is seen. Movement of hematopoietic stem cells to spleen and liver. There is presence of hypocellularity, decreased cells with increased deposition of reticulin inside the marrow, abnormal megakaryocytes, and characteristic finding of dilated marrow sinusoids. With this chapter is over and the whole of white blood cells is over. Okay.